So good cases, but who wants to give this one a go?
Is it a trash can?
What do you need, trash can?
Chewing gum. That's all.
One thing I will not do is
That's fine.
Just swallow it.
I just did. No problem. Alright, so basically this one is a shade biopsy of probably a papule.
Yeah.
And the epidermis didn't look really altered, or maybe a little bit acanthotic, but the main thing is happening in the dermis.
Yeah. So it's, you think it's more an inflammatory or neoplastic
I
process?
thought this was a neoplastic process.
Good. What's the pattern?
So that's an interesting question. So the pattern looks almost nevoid. Like
Yeah, there's a lot of nests.
Yes.
Good. So it's a nested
Mhm.
process.
Yeah.
So that kind of, and you think it's benign or malignant?
I thought from this low power, I thought it was benign.
Yeah, it's fairly small. It's, again, we don't have the whole thing, but if we kind of drew a circle around it, probably kind of look like that. And it's mostly nested. So yeah, so when you think about nesting of things, you think about relatively few things can give you nests. So what were some of the things that you thought about?
So the first thing comes to mind is melanocytic lesion.
Good.
There are certain like neural structures that can look a little bit nested, but
Yeah.
and I'm not sure if there are many more things that can give you.
Some epithelial lesions can sometimes be nested in. You see like nesting sometimes in the squamous cell and basal cell. But generally you're right. I mean, you want to think about things like melanocytic neoplasia in the skin at least, and then sometimes neural lesions can do it. And you said what kind of neural things were you thinking about?
Well, I mean, with this distribution and like a neurofibroma, but it doesn't have the aspect of a neurofibroma, and like a weird, like really odd schwannomas that we have seen can have like this mucin and like mucose.
Yeah, that's it. You've got mucin here, and then you've also got these epithelioid cells arranged in the nests.
Yeah.
So there is a neural neoplasm that gives you that.
So
I also notice these kind of struts of collagen between the individual aggregations. That's kind of a helpful finding.
So my nightmare with neural tissue things is neurotheciomas.
Yeah, this is a neurothekioma, and it's kind of a hybrid. It's kind of got some cellular areas here, and it's also got some myxoid areas there. The other type of neurothekioma is just the classic neuroshoot myxoma that gives you lots of mucin with more spindle-shaped cells. This has got some features of cellular neurothekioma as well as
that pretty much confused me because of that, exactly, because of the two features in the same. So,
yeah.
But yeah.
So these things don't usually read the textbooks, but these are what these can look like clinically. They're usually just kind of a dome-shaped subcutaneous kind of nodule. So this was a cellular neurothekioma. It also had some myxoid areas to it also. So what stain would you do if you wanted to confirm the diagnosis?
So I think S100 will be positive.
Close.
S1 is what's it? S186.
I've never ordered that stain, but there's one called NKIC3 or CD63. That's the one that stains positive. But it is actually S100 protein negative. And the other thing about this that can be seen, sometimes you get some atypical cells with mitotic figures and those kind of things. Are they seen when we show the slide? Do we need to toggle over here so the people on the line?
Can I split?
So they can see it here too.
Yeah, we're good.
Perfect. Okay. All right, so good. Cellular neurothekioma. Kind of a relatively rare entity, but something we at least need to know about. So we have a lot of little adnexal things today.
Okay. So we have a shave biopsy, and the action is in the dermis.
Good.
It looks very basophilic, low power here. And there's like aggregations of cells, but they're kind of well, they're very close to each other.
Yeah, they are. I've noticed Friday. Okay. All right, so did you favor like a benign or malignant?
Benign. It's
Good.
all circumscribed, and I didn't see any here.
Good. What kind of differentiation did you think you were looking at here?
Initially, when I looked at it, I considered follicular just because of the basophilia. But then you could see that there's like these spaces too with like glandular spaces.
Yeah, there might be some little tiny, like that's probably a little duct right there.
Mm-hmm.
There's definitely a duct over here.
Mm-hmm.
And then what do you see around the individual aggregations?
There's dark, it's like a dark outline, and then pink
Yeah, there's like a
hyalinized
pink, good.
collagen.
Excellent. It's probably PS positive based on the own material surrounding a lot of these. And notice how they kind of fit together like a little jigsaw puzzle.
Mm-hmm.
So what was your diagnosis?
Cylindroma.
Yeah, good. Cylindroma. And is that, we call them ecrine cylindromas. I think some people say they're probably really apocrine differentiation. Now, is there anything you need to be worried about if somebody has a cylindroma like this?
I don't know.
That can be associated with a syndrome, Brooks-Spiegler syndrome, especially if you get like features of a cylindroma and a spiroadenoma in the same lesion. But that's it's a benign process. It's just an interesting kind of genetic, autosomal dominantly inherited process with multiple cylindromas and spiroadenomas. And this is what they can look like clinically. They can be really, really large. Rarely they can undergo malignant degeneration. It's very uncommon that they can. So this is pretty straightforward. I think the main thing is just you wouldn't want to confuse this with a basal cell or something like that. So remember the sort of jigsaw puzzle and get that PS positive material that kind of surrounds the individual lesions. And then you should know what the Brooks-Spiegler syndrome is in boards. I'd like to ask you about syndrome. Okay. Yeah.
Lymphocytes here as well.
There's a few lymphocytes, I would agree, inside the area. What else did you see?
Some pink cytoplasm.
Yeah, you got this sort of pink little globules in here admixed with the very small cuboidal cells that are somewhat basophilic and some even have a little clear stained cytoplasm. So what was your diagnosis?
Oh, that's xerosarcoma.
You
Oh,
said-
spiroadenoma.
Okay, spiroadenoma. I think you just said wrong. Yeah, you meant spiroadenoma. I know that.
Spiroadenoma.
Because you said blue balls in the dermis. That's the
Yeah,
thing
that's
that
spiroadenoma.
think about, right? Now, is everything that's blue balls in the dermis spiroadenoma?
No.
Of course, the answer to that is no. What other things can give you that morphology sometimes?
I mean, sometimes you can see like the BCC like that, or trichomotiloma, trichoepithelioma, lymphoma.
Lymphoma probably, yeah, and maybe Merkel cell possibly. There's a thing called a lymphadenoma. Cutaneous lymphadenoma, where you get basically kind of almost looks a little bit like a spiroadenoma, but it has a lot more lymphocytes within it. I'm not sure what that is. It might be sebaceous differentiation. But this is spiroadenoma, and again, this, if it's associated with cylindroma, it can sometimes be seen in association with Brooks-Spiegler syndrome. Is there anything about this lesion clinically that would be important to know?
Like this particular one on the slide.
No, just in general.
Like it can be painful.
Yeah, they're painful. So one of the painful tumors, that's probably the most well-known mnemonic of any mnemonic device in dermatology. So every resident has learned the painful tumor, so you make sure that you know those, obviously. So this is spire adenoma. Okay, everybody got that right? Please. Gimme. Okay. Now this one's interesting. I'm not sure I totally agreed with the final diagnosis here. I kind of changed it when I saw it.
Yes.
But
this
you can
one
get it
was
into the right
interesting.
category.
I believe it's in the adnexal follicular.
Yeah, good.
So I kind of thought, with this large, it's the shaved biopsy with capital. So kind of in the center there, there's this kind of infundibulum bar
Good.
opening. And from it, there's a follicle, and around it, there's surrounding our little follicles. So I kind of thought of trichofolliculoma here, but it wasn't really a classic trichofolliculoma. It also had kind of some features of a trichoep.
Yeah, it's sort of like a little primitive mantleoma. The mantle zone is right here, around this little primitive infundibulum. And there's actually 3 of these in the same specimen. There's one over here, here's another one, and then there's a third one over here. And notice how it's pedunculated like this. So what was your diagnosis?
Because it's pedunculated, maybe a trichoep?
It's not really perfect for a trichoep, and sometimes when it sort of has features that don't really fully express themselves.
Follicular hamartoma.
Yeah, it's called benign follicular
Okay.
hamartoma, and there's a
Benign follicular hamartoma.
there is a benign, there's a follicular hamartoma syndrome. It's like you can get multiple trichoeps, you can also get multiple of these. So people argue about these. Some people say, well, if they're really basal cell carcinoma variants, they call them infundibular cystic basal cells. I don't like that in this case because there's 3 different individual lesions, which tells me it's almost certainly hamartomatous. It's a shaved lesion that they kind of got the whole thing out. It's very well circumscribed and small, so I think it's probably just benign follicular hamartoma, even though it's a little bit more cellular than on this side than the other one. So, you might want to treat it like possibly basal cell. Is there any situation where you can see lesions that look like benign follicular hamartomas clinically and histologically, but they actually do have basal cells also? If you biopsy these early,
Yeah.
show the clinical slide. Just look anything like that clinically, because this is a pedunculated pathule, so go to the next slide. But basically, you can see in early nevoid basal cell carcinoma biopsies of basal cells, sometimes they kind of have a follicular morphology.
Like in Gorman's or?
Yes, Gorlins. You can sometimes see a little follicular morphology to some of the basal cells. And they also have superficial basal cells, nodular basal cells, sclerosing basal cells, any kind of basal cell. But I didn't think this was really a basal cell this time. I thought it was more like a hamartoma. But they can look similar, and people argue about them. There actually are some stains that you can do, try to distinguish between these. Burr, EP1, and there's another one. I've never really used those stains. To me, when you look at something like this, they probably got the whole thing out with a biopsy. So anyway, that's follicular hamartoma / infundibular cystic basal cell carcinoma. I presume you guys got that right. Okay, this is a good one too. This is a very nice example. This could be a board question for you.
Alright, so a very thin shaved biopsy. It's like non-nacral skin, but from low power you can see this kind of thickening of the stratum corneum, and I think there was some parakeratosis.
Okay, yeah, it is parakeratosis.
So yeah, parakeratosis, and I thought,
What was the pattern of the parakeratosis?
It's kind of on the quote-unquote shoulders of the ostium, but it's pretty much diffuse.
Yeah, it's pretty confluent.
Yeah.
It's like it sort of spares some of these little osteoids. Here's some vascular we quantified later coming out of a couple of those infundibulum, but basically it's sort of adherent and it's confluent over the entire lesion, the entire front. And then when you look at it a little higher magnification, what else do you see here?
So I was trying to figure out what is going on in the surrounding hornium there. I was looking for hyphae or bacteria or
Yeah, it's
anything there.
really not any of that, is there?
No. I guess it's just breaking apart. I'm not really sure what.
Well, it's kind of got all this granularity to it, and there might even be a little bit of focal calcification up here. So it's granular, and this is part of the deal here. You see this repeatedly, and you know what? We're not actually 100% sure what that stuff is. It's not just dirt. This actually kind of goes along with the process. It's probably some sort of degenerative material related to sweat and possibly to axillary secretion. And then you get this broad zones of parakeratosis like you see here that's pretty confluent. And you get a little bit of psoriasis microplasia, not a lot, it's not psoriasis. Does that ring any bells?
So with all that, I would think, well, originally I thought sebderm, but with all the kind of schmutz and other stuff, then maybe more like terrapure.
Well, there's one other item. This terra firma formi doesn't give you this kind of confluent parakeratosis. This kind of gives you all, mostly is this junk.
So it's like, well, I wouldn't think this is enough for granular parakeratosis, but
It's probably about as good an example as you'll ever see in your life.
okay. I guess I've seen
Yeah,
ones
the
where it's
one-
much thicker and I don't know.
No, this is perfect for it. This is very good for it.
So the granules can be loose, like
Yes, absolutely can be used.
Like
Yeah,
this.
because we would see it in the
Yes,
parakeratosis.
exactly.
It's really, really blue, but I think it's just a different this one.
Yeah, this is a variant of it. This is what you see. This is axillary granular parakeratosis. This kind of confluent parakeratosis is very, very characteristic. Very adherent, confluent over broad front with this material also. Notice that that's in between these little wafers of parakeratosis. It's not just purely on the outside. It's inside here. So this is part of the process. It actually is, some people think it's some kind of degenerative condition. Some people think it's related to using deodorants, but it's not only confined to the axilla. You can see it sometimes under the breast, you can see it sometimes in other locations. It's kind of what it looks like. Probably some of that stuff may be terra firma forming as well, but this is a pretty nice example of, in this case, it was axillary. Okay. Did you not get it, or you did get it?
I did not get it.
You got close, right?
I got close. Okay.
All right, this is a fantastic, beautiful example of this
Yeah.
entity.
So this is a punch biopsy, and the striking thing from the low power is there is this edema in the upper dermis, almost, yeah, almost.
Which part of the dermis is that?
Papillary
Good,
dermis.
papillary dermis, excellent.
It's almost like blistering, but it's not.
It can blister. Yeah, if you get massive papillary dermal edema, it actually
Mhm.
can eventually separate the epidermis from the dermis and form a subepidermal blister.
And then the other striking thing is well, it's perivascular and periadnexal lymphocytic infiltrate. It goes quite deep.
Yeah, superficial indeed.
Yeah.
Beautiful.
So when looking into a biopsy, the differential for dermal edema would include arthropod bite, but there were no EOs or there were no wedge.
Good,
PMLE, which is what this is, I think.
good.
And then tinea, well,
Good.
a bit,
Yeah,
yeah,
you
tinea
should think
can-
of tinea.
Mhm.
Absolutely. Bullous dermatophytosis gives you
Yes.
massive papillary dermal edema. That's very good.
And then that there was no microorganism to be found.
Good. That
and-
usually would give you more neutrophils and some things like that. So it's not usually
Yeah.
sufficiently lymphocytic.
And then the other one is sweets that usually
Good.
would give you like a sea of neutrophils.
Excellent.
And there are a couple more that I don't recall right now, but basically my thought was this was PMLE.
Your thought was right. It's a classic example of PMLE. Now, what are some other forms histologically that you can see with PMLE? So if you get somebody who comes in with kind of a non-specific photodermatitis, it looks pretty good for PMLE, you biopsy, and it doesn't look like this. What are some other?
It can be just spongiotic, it can be
You
just...
can. There's a papullovesicular type. It can be kind of a spongiotic dermatitis. It's usually superficial and deep, though, with some spongiosis.
I'm not sure. Well, it can be urticarial maybe too, because...
You can get some that just looks like a lymphocytic infiltrate. Yeah, that can look urticarial clinically. It doesn't have any EOs histologically. The papullovesicular variant can sometimes have a couple of eosinophils.
Okay.
But it's those are the main types, and then you can get some where you can get things that look a little bit more like hydroa estivale, hydroa bacteriformis. You actually maybe have a couple of these keratotic keratinocytes here. One of the rules of thumbs about photodermatitis, when it's photoexacerbated, it tends to be deeper than if it's not photoexacerbated. So superficial and deep goes along more with photo than if it's non-photo. So photo drug, for example, it's going to be a deeper infiltrate often than the non-photoexacerbated. It's such a beautiful example of photodistributed eruption here. So just remember, this is like a textbook example of PMLE. Everybody got this one, right? Good. And that's a good differential for papillary dermal edema also. Okay. You still in focus here? No. All right.
Okay. We have a shave, maybe a wedge shave, a deep shave biopsy, and it looks like the action here is in the dermis.
You know, it may actually
Is that the top?
be a
was it
punch biopsy,
Oh,
possibly, but it's kind
Wasn't
of funny.
sure
But
if
you're
that
right, it
was-
goes pretty deep.
transected?
It could be. It could be like a deep saucerization, and they
Yeah.
just whacked off the epidermis. That's a possibility.
Well,
This actually could even be the lid of this. Maybe I doubt it, but that's possible.
And I see that the process is in the dermis. It looks more from low power neoplastic versus inflammatory.
Good.
And from what I recall, here it looks, kind of borderline well circumscribed, but I think I saw atypia whenever I got closer, so I was leaning more towards malignant versus benign.
Right.
And from here I could see that there's ducts or glandular spaces.
Look at everything there, very into there. Some of that plastic, not just rubber, if you're seeking to find it. So neoplastic is correct. And did you favor malignant or benign?
I think malignant because I saw atypia, and I see that there's these ducts in there too.
Yes. So what was your thinking?
I don't know a lot of, so some glandular, eccrine versus apocrine differentiation is a little bit more.
Yeah, they could be. So do you think this came from the skin primarily or not?
No, it might be like
They were up
Metastatic.
there on these. There's two of them I had that were on these in plastic coating rather than this rubber. They're probably sitting in one of these, not those.
Okay.
You're doing well.
I
I'm
think
sorry,
it could
Mrs.
be
Stratton.
metastatic. I thought maybe like an adenocarcinoma.
Good. Which one? Which one gives you the cords and strands of cells between the oncology bundles with some glandular differentiation? Look, this one's sitting inside of
breast?
lymphatic. Breast, yeah, this is breast cancer. And there's the nuclear molding. Is that it? This is it. Yeah, this is not it. This one doesn't have anything on it. So somebody may have been on it at one point, and pulled off, so you can find. Actually, this isn't it either. It's got They have plastic coatings on it. This rubs every time my glasses touch it.
Yeah, that was so cool.
I'll check those out. Are those,
Oh, what are yours are?
those rubber? Okay, well, we lost it, I guess. Okay, so this is metastatic breast cancer. The thing is, they might put something on the board that says which of these is most likely diagnosis. So why is it not, for example, metastatic colon cancer?
Why it's not?
Yes.
I think well, I'm not sure how undifferentiated things like this can become. Usually in intestinal or colon you have goblet cells and things that you don't have in breast.
That's just metal.
Right.
Yeah.
Okay, well, somebody didn't get that, unfortunately.
You can become super undifferentiated.
Yeah, basically, those have larger glands with so-called dirty necrosis, and they look like the GI tract. So if you see, if they have a lot of glands that have like goblet cells in them, that's more likely GI. But this really wouldn't be very good for metastatic squamous cell because it's got all the glands. So basically, if they're going to put something on there, they're going to ask you to tell the difference between some of the major ones that you should be able to tell the difference in. So that's metastatic breast. There's several different forms of it. The bad type is the one you see right there, the carcinoma pleurosa, which kind of comes back and forms a big massive shield of cancer cells. So, did you guys get this one?
Yeah.
Good. It's pretty straightforward. And so, if they're going to show you something metastatic, it's going to be something like this. It's going to be pretty obvious. Okay. All right. Cutesy.
Yeah, so this one, at first I had a little bit of trouble with it, trying to decide, if it's kind of a human entity that's coming out or a non-human entity that's going in. At first I was kind of thinking that maybe this was, like this basophilic material that was protruding from the epidermis.
Yeah, what is all that stuff?
It looked kind of like, at first I was thinking it was collagen, like a reactive perforating collagen basis.
There is something perforating, isn't it?
Mm-hmm.
It's basically transepidermal elimination.
Yeah.
So all this stuff, these are neutrophils here. There's some degenerated collagen, maybe some squames. So it's got a little channel.
Mm-hmm.
So whenever you see something like that, you say, well, why is it perforating? What's going on here? And then if you look over on this piece, what is that? I'll look at here. These are different.
Just like a piece of.
Plant?
It is plant. So these are
Cell wall?
cells in your epidermis. These are cells of plants. These are individual plant cells.
Super thick cell wall.
Yeah, it's got glycosamine, glycan, whatever, cellulose, that sort of stuff out here. So this is a splinter, probably like a little thorn, might even be a rose thorn, something like that. And so basically what's happening is this person's trying to get rid of it. It's trying to be transepidermally eliminated. So you've got maybe some histiocytes over here possibly. It's got a little granulomatous inflammation as well. So basically it's a splinter reaction with a suppurative response. So what one thing do you kind of have to worry about in a splinter when you get a splinter?
If it's like an infection.
Yeah, it can cause an infection, but sometimes the splinter will contain dematiaceous fungi because it's living in the world, obviously, in the soil, and you get the dematiaceous fungi that grow inside the splinter, and then you get a splinter reaction, and you see the dematiaceous hyphae in here. It doesn't mean that they have you know, chromoblastomycosis or anything like that, but you'll often see dematiaceous fungi that get sort of implanted within the splinter. So here's what it looks like. You know what these things look like clinically. But sometimes they'll just kind of work their way out and don't have to actually remove them. So this guy, they took a biopsy, probably because they thought it might have been a wart or some kind of cancer or something. So frustrated. It turned out just to be a benign little splinter reaction.
There you go.
Okay, so here we have a shaved biopsy of a papule, and it looks pretty crusted and eroded. And there's a proliferation of vessels,
Yes.
especially in the vessels. I appreciated kind of this hobnailing or the prominence of the individual cells as well in the vessels.
Do you think it was benign or malignant?
Well, I thought it was benign.
Good. Good. It seems to be fairly small. It's pedunculated. It's fairly well circumscribed. It's got a possibly little collaretive epithelium over here, and maybe on this one too.
And a lot of kind of just smaller vessels with these larger vessels and endothelial cells. So I thought this was a pyogenic.
Yeah, good. This is just basically lobular capillary proliferation. It's granulation tissue. Comes about as a manifestation of trauma. So the neutrophils on the surface of it. Okay. So what was your differential diagnosis? So you say, okay, this looks like a pretty obvious PG, but then you're looking down at a multiple choice question, and there's several choices, try to trip you up.
They might put capices on there.
Yeah, they might. You would never fall for that,
No,
right?
no.
Good. No slit-like vascular spaces.
You know, they might try and put angiosarc on there, or maybe like some other vascular neoplasm, like a targetoid neocerotic hemangioma, just because they're kind of almost lymphatic looking vessels top here.
What if they put Mason's?
Well, I don't think Mason's tumor would be a good choice because there's no fronding, it's not one large vessel.
Good. Yeah, it's basically not within a large blood vessel. Those are actually known as intravascular pyogenic granulomas, so it sort of looks somewhat similar. You just look at the individual cells. What if they put metastatic renal cell carcinoma down?
But there aren't clear cells, you don't see pleomorphism.
Good. What if they put bacillary angiomatosis down? That could look pretty similar.
Could look kind of similar.
Yeah, that probably wouldn't be a fair choice because these things they can look a lot like pyogenic granulomas. If they did put it down, they'd probably say this stained positively with a special stain for microorganisms and have this morphology. What stain would you be thinking that they would have done?
For bacillary?
Yes.
That is caused by Bartonella.
Yes. And what stain highlights the organisms? There's two stains. There's one cheaper stain, and then there's an immunoperoxidase stain that is directed to Bartonella, but
it's gene stain with that to it?
anybody know?
I think it's working.
Swarth and starry silver stain. Yeah, it highlights the organisms. So if you want to see the organisms with DNA, you have to do a silver stain, and they form these large clumps. Go to the next slide there. The black material, it even almost looks like an artifact, but it's not. It's actually the organisms themselves. Okay. So, everybody got this one right too, I take it? Straightforward. Okay. This one.
Punch biopsy here. Lots of, it's like mostly inflammation in the dermis.
Yeah, what's the pattern of the inflammation?
And there is some, I think, some PEH, but
There is a little bit, yeah, I agree with
most of it
that.
I think would be just granulomatous.
Yeah, it's kind of a nodular and diffuse infiltrate, isn't it? And yeah, a lot of the cells are pale, so they're going to be histiocytes. Some lymphocytes here too. Maybe even some plasma cells with a higher magnification, but definitely get a lot of pale cells that are histiocytes. And then you got this pseudoepitheliomatous hyperplasia. So what's the overall category that you're thinking about here?
Infectious.
Infection. And a lot of different kind of infections out there. Which kind of infections usually tend to give you a suppurative granulomatous derm or granulomatous dermatitis with pseudoepitheliomatous hyperplasia?
So like pH with pus and all that, so lots of different deep fungal infections, things like leash. Those are the ones I look for first.
Now, and also, yeah, I think, atypical mycobacteria. Now, what about these cells that are kind of pale?
So these cells, I think were at one point normal histiocytes, but I think they have a few organisms that are inside them.
Okay. Any specific type of organisms?
I believe this is leash because I think I saw the marquee sign around the edges there.
Good. Absolutely. Anything else about the organisms that you can tell?
Well, you can see them, so that's things like histo can also sort of give you a sign like that, right? But they're much smaller.
Yeah, and histo usually doesn't line up around the periphery like this. They usually are more like this, diffusely inside the cells. And with this nice high power, you can actually see the little kinetoplast here. The little dark structure right there. These actually ultimately flagella form there. What? So anyway, these little dark structures right here, it's hard to see on the TV, but you can see it right there. Eventually, when these things go through the stage where they actually form flagellated organisms and swim throughout your body, that's what actually is powerhouse for the little flagella that forms it. You can really see it nicely, at least in the microscope. It's not as good on the TV, but still you can see it. So if you see that, it's pathognomonic of leishmaniasis. Of course, you see the marquee sign. Now, is the marquee sign seen more commonly in the old world or the new world forms?
50-50 shot.
You do. 50-50 right, 50-50 wrong. Take your pick.
New?
Good. Good guess. Greg, you got it. It's more common in the new world type than the old world type. I don't know why that is, but it seems to be more common. And this also, notice, it doesn't have as many, it doesn't have really the classic suppurative granulomatous pattern that we see with like sporo and some of those. This has more granulomatous infiltrate in plasma cells as opposed to the suppurative granulomatous infiltrate. So plasma cells there here. So this is leishmaniasis. This was, I believe, this was a New World case. Now, can you see New World cases in the United States? Yeah, you see right around here. You see it, we see probably a case every couple months or so, I say here. Then these people, so don't even have to be, they never leave. It's not like they go to Mexico and get it, they just actually invent it right now in good old North Texas. How do you treat it? Yeah, the antimonials is kind of a classic way. I think actually even some of the oral antifungals have been shown to work for this. Okay, this is a great one also. Diagnosis at low power if you're really, really good.
Well, I'm not that good. So this is a punch biopsy, and from low power, what you can see, the epidermis looks normal to a certain corner also. There's some sort of infiltrate in the dermis that goes quite deep.
Yeah, what kind of, can you tell anything about this infiltrate?
So it's not lymphocytic.
Good.
It doesn't
Excellent.
look like histiocytes.
Good.
I honestly, from lower power, I will not lie, I cannot really tell from.
But you can kind of start doing as a diagnosis of exclusion.
Yes.
Not lymphocytes, not
Yeah.
histiocytes.
Yeah.
Not neutrophils.
They don't look like neutrophils or eos.
Okay. So what does that leave?
That leaves mast cells.
Mast cells.
But I wanted to go in higher power to see.
We'll let you go to higher power in a minute. You know, we'll get there.
Because
But yeah, notice one other thing about them. They seem to look pretty kind of monomorphous.
Yeah.
One looks like the other one. So those are all clues if you're dealing with mast cells when you're looking at low power. Of course, you go to higher magnification, and then it's a snap.
Yeah.
Easy. This power.
Mm-hmm.
Yeah, they all look like little fried eggs.
Yeah.
And if you cut them longitudinally, they kind of look like little hot dogs.
Yeah, the hot dogs.
Okay, so fried egg and hot dog right there together.
Yep.
So these are all mast cells. And notice that it's got the nice, abundant granular cytoplasm.
Yeah.
Okay. So, any concerns about this patient?
Well, I mean, the patient has.
How old is this
muscular
patient, by the way?
Probably young.
Yeah. It's a punch biopsy that's a small little punch that goes all the way through the skin. So it's probably a little kid or baby.
Mm-hmm.
And this type of mastocytosis, where you get lots and lots of cells, what would you actually maybe call this?
Like systemic or something?
Well, you might call it a mastocytoma.
Oh.
And, you know, when you see like a mastocytoma in kids, like a solitary lesion,
Yeah.
they often look like this. They have tons of mast cells in it like this. So, yeah, you might want to make sure the kid didn't have a systemic
Mm-hmm.
process. They most of the time don't. Would you go into the clinic and try to get a Derrier sign on this?
I probably wouldn't.
Good.
No.
Why not?
Well, you can trigger like an anaphylactic.
You can trigger anaphylaxis. You can also get bullous
Yeah.
mastocytosis when you go in and vigorously rub these kind of lesions. You don't want to do that. Okay, good. So this is mastocytoma, mastocytosis in a child. This kid's got a lot of them. And that was probably a solitary lesion. So there's a lot of different histologic forms. You know, the TMEP form, you see just a really sparse number of mast cells with H&E. It just looks mostly just like a sparse superficial perivascular dermatitis, but you stain it, and then every cell is a mast cell. And that's how you distinguish that. Sometimes these can look like XGs histologically. That's probably the one thing that I've seen that gets confused with it sometimes. You can do a mast cell stain if you want to do that. So what are your favorite mast cell stains?
Alcian blue. No, Tolidine blue, sorry.
Tall blue will stain them, and,
Yeah.
and Giemsa will stain. Those are what we call metachromatic stains, except you stains in purple. There's a couple other stains that you can stain specifically for mast cell products. Tryptase is one that we use. The guy that sent us a C, what was it, C117 or something like that. So we do that C kit. That's another one we do. So those are all stains that you can do. That's could easily be a board examination question too. Okay. This is a very nice example also. We've got some really good examples of these for you today.
Okay, so we have, I will preference this with the fact that on the electronic slides, I could not see it. This was like blurry,
It was a little bit out of focus. Yes.
right? So I couldn't really preview this one, but I could see that I could at least see that there's some sort of infiltrate more in the like reticular dermis or the and it could be a little like maybe
Okay.
more they're forming maybe a little bit more nodules.
There are, and they're mostly around blood vessels, so kind of a little nodular infiltrate, perivascular, a little bit interstitial. What kind of cells do you think these are?
There's at least some lymphs there.
A few, but it's not jet black like the case of polymorphous
No.
line rush we had earlier, was it?
No.
So they're a little bit different, sort of salt and peppery looking. So when you see that, what do you think about?
Maybe some histiocytes and
Histiocytes are good. Newts, yeah, neutrophils. A lot of polys in this lesion. Let's go to even higher magnification.
There's a lot of extravasated.
A lot of extravasated red cells. Good. What's all this stuff?
These little dark spots.
Yeah, what are those little dark dots? They're not leishmania this time,
No,
right?
so there's some sort of
Yeah,
Nuclear degree?
yeah, nuclear debris. So what do we call nuclear debris, especially of neutrophils? It is a form of, it's keratorex, but it's not only keratorex, which means like the nucleus is gone. It's like the entire cell is gone. Leukocytoclasia. And what's going on here in this blood vessel?
Oh.
What's all this pink stuff?
Yeah, so it's I'm not losing words right now. So there's like it's thickened, the wall's thickened, but there's
It's got
cells,
fibrin.
Fibrin. And
Fibrin is present in the wall of this blood vessel and it's degenerated. So what's the diagnosis?
So like LCV.
Yeah, leukocytoclastic vasculitis. It's a beautiful example of it. It's got everything you want to see. Neutrophils, nuclear dust, the eosinophils, fibrin in the walls of the blood vessels being destroyed and damaged. And it's got more neutrophils and eos, lots of leukocytoclasia. What disease is this more likely to represent, given that it's got lots of polys? That's kind of a clinical pearl. Which of the vasculitides do you get mostly neutrophils? Do you get pustular vasculitis? Is that more like common with the vasculitis you see with connective tissue disease? That's okay if you don't, I'm not sure. Does anybody know?
I wouldn't have thought.
IgA-mediated vasculitis tends to give you more polys, more pustular vasculitis when you get HSP. So I think this actually was an example of HSP. This is palpable purpura, a beautiful example of that. And then, I don't know, we just call this LCD, but this is the most common form of LCD, we get lots of polys, is HSP. So if you wanted to document that, next slide, what would you do to look at it and prove that it was HSP? Yeah, and what do you see?
IgA.
Granular IgA inside the blood vessels, if you get it at the right time. If you get a late stage lesion, it may already be gone. You have to kind of get it within the first day or so, really, to be definitive. But it's most commonly, you get lots of polys, think of HSP or IgA-mediated vasculitis. Okay. This is also a nice example.
So with this one, like punch biopsy here in with the, I don't know if that was like a artifact, kind of where the epidermis is kind of softening off, but then I maybe was thinking I was actually part of the process.
Yeah, what's the pattern that you're looking at here?
In like a superficial, here's like a bullet, like a
It is, it's a blister.
blister.
It's
Yeah,
an
blister.
intraepidermal vesicle, and there's three main ways that you can get intraepidermal vesiculation. You know what those are?
Like an infection?
No, although infection can cause that, you're right. But what are the three main sort of pathophysiologic mechanisms that you can get intraepidermal vesiculation? Anybody want to help her out?
Like acantholysis.
Acantholysis is one. What are the other two main ones?
Like
Okay, what kind of edema?
Like a
If it's intercellular edema, what do you call that?
ballooning.
Ballooning degeneration. And what's the last one? When you get intercellular edema. What's that called? Spongiosis. So those are the three main ways. There's a couple of others. Acantholytic dyskeratosis. Some people consider that, and then epidermolytic hyperkeratosis. But those are the main ones. So which of those are we dealing with here?
Other thing is, cantholitis.
Yes, acantholysis. And where is the acantholysis located?
In the superficial
The
epidermis.
upper part of the epidermis. Good. So what's the diagnosis?
Well, it affects the staph scalded skin.
Possibly, but notice that this is not just subcorneal, it's really down inside the epidermis here, that intragranular area.
Pemphigus foliaceus.
Yeah, superficial pemphigus, pemphigus foliaceus. Another clue is if you see involvement of the follicle, you don't really see it in this one that well, but that's another clue that it's a real process. Now, you mentioned staph scalded skin and pulsatigo. Those are also can give you similar patterns, so you'd want to do immunofluorescence here. And it was positive. Here's a good example of that patient.
So Snedden-Wilkinson.
Snedden-Wilkinson, that is not an intraepidermal acantholytic process. It's more of a subcorneal pustulate process.
Yeah, so it's subcorneal, so you wouldn't see the acantholysis.
If you do, it's minimal. It's not a lot.
But it can still happen.
Yeah, it happens, but it's secondary. It's not the primary process. So this slide gives you a little sort of tell you about all the different patterns of immunofluorescence there, which is kind of interesting. This is basically a acantholytic process, which would be similar to pemphigus. Now, sometimes in pemphigus vulgaris or pemphigus erythematosus or any of those, you get it throughout the epidermis. It's not just localized to the top, so you can't just tell the pattern. The diagnosis is based on the pattern by IF. Okay, two more here.
Okay, so here we have maybe it was a shade.
Okay. Any idea which part of the body you're on?
Or mucosa. It's an appreciated granular layer.
Okay, good.
Yeah, I just saw these vessels that, I didn't really know what to think of this one because I saw all these little vessels and some kind of fibroblasts, but I really wasn't sure what this was.
Well, let's work through it. You think it's mucosal. Is it benign or malignant?
It looked benign.
Good, very benign, small, round, little circumstructure, little pedunculated papule.
It kind of reminded me of angiofibroma.
It looks a little like angiofibroma. It does. It's also got some pretty thick collagen. So it could be an angiofibroma, but what else can give you a papule on the mucosal surface where you get some thicker collagen bundles like this? That's associated with some acanthosis, which you usually don't see in angiofibroma, and even some hyperkeratosis and hypergranulosis. Normally, you shouldn't see any granular cell layer. Here, you've actually got a granular cell layer on this membrane with thick cornified layer. So, what does that tell you?
Could be a cyst.
Well, no, it's not a cyst, but you normally shouldn't have this thick.
Yeah.
So what causes the cornified layer to get thick when it shouldn't even be there? Yeah, he's
Rubbing,
rubbing,
like
trauma, exactly. So this is mostly related to trauma.
Okay.
So what's the diagnosis?
Is it from kind of chewing the
Yeah, it's called
cheek?
an oral fibroma, bite fibroma. People just bite their lip, they get this kind of thing, it kind of keeps going. It's basically analogous to prurigo nodularis on the mucous membrane. You get these dilated thick blood vessels and thickened collagen bundles. It's basically just a benign lesion and it's associated with chronic trauma. So normally your mucous membrane shouldn't be this acanthotic at all. It shouldn't have this thick cornified layer. So those are all things that kind of tell you that it's definitely been traumatized. Okay. One more here.
Alright, so we have a punch biopsy, endophytic lesion. I think even from this power, you can see the follicular differentiation.
Good.
Yes, follicular cysts. So the shape of this kind of immediately led me down the kind of spectrum of poor whiner, pilar sheath, acanthoma. I don't think that it is large and it has enough to be considered like a trichofolliculoma, so I was thinking more in the middle, like a pilar sheath acanthoma.
Yeah, I think you're in the right category. You can see that it's basically a cyst, and the lining of the cyst is these little small primitive follicular structures, but they're not really papillary mesenchymal bodies. Maybe that one's trying to be a little bit of one there. But they're more these kind of little small solid tricholemal aggregations over here. And that kind of goes a little bit better for a dilated pore of Weiner. A pilar sheath acanthoma can kind of look similar to this, only these are usually larger lesions and the cystic component is usually less in that condition. But it's kind of a spectrum. So if you're in that category, you're fine. Nothing to worry about there.
So you favored dilated pore whiner because of the.
Yeah, the nice cystic central component, and these are not as large and as variable in size and shape as you usually see in a pilar sheath acanthoma, but I wouldn't lose any sleep over that because they're not going to ask you to distinguish between that and the pilar sheath acanthoma.
They did.
Who did?
At the American Board of the AD meeting,
Well, that was
the
a
test.
training session.
It was a training session, but still.
Well, they're not writing tests.
Okay, good.
I can tell you they wouldn't do that.
They were fine tuning there.
If it appeared on the in-service exam, it means it was rejected from the regular exam.
Okay.
Because I used to be on the exam committee, we'd say, no good in-service. So we throw it over the in-service.
Really good.
And that's the case.
There's some
So,
crazy questions.
but if you know, that's just because it's not really, number one, it's not that important. Number two, it's often somewhat slightly controversial. The fact that this has a larger cystic component favors the dilated pore line. That's not something to worry
Very good.
yourself
Thank you.
over. So, okay,
Thank you, Dr. Cockerell.
Thank you.
Thank you very much.
no questions?
All good.
See, I had Mokhtar 3D print this with plastic. He had to go out of his way to do it. Somebody decided they didn't need it more than me.
Yeah, I haven't seen
Oh,
I
it.
think he had, I think he's making the extra. It looks like ours in the other room when you fit on this. Because with glasses, this kind of rubs on the rubbery stuff. It's not good.